Muted.
Okay. All right, I'm going to introduce our speaker for today, Dr. Greg Oceanic. He has been the medical director of the Center for Neurorehabilitation Services in Richmond, Virginia since 1991. And that website there is his website there at Neurorehabilitation Services, and that's a great resource for more information, or maybe you can get some of your questions answered there. After attending Ohio State University, he entered the University of Texas Medical Branch at Galveston and received his MD in 1977. His postgraduate studies were at Duke University Medical Center. His academic career included faculty appointments at Duke University Medical Center, the University of Texas Health Science Center of Houston, Medical College of Virginia, and most recently the Department of Neurological Surgery and the Virginia Neurological Institute at the University of Virginia. He's authorized more than 100 publications, including editing and co-editing 3 textbooks. As a result of his international reputation in neuropsychiatry and neurorehabilitation, he was asked by the first National Medical Director of BIAA in 1996, a post he vacated in 2010 when he was elected chair for BIAA's Board of Directors. So I'm going to turn things over to Dr. Oceanic.
So with all that, we have no more time for a presentation. Thank you very much for attending. No, just kidding. Sorry. Deborah, thank you very much. Very kind. And I apologize for getting started late. I'm somewhat technology challenged. So as she said, what we're going to be talking about today is neuropharmacology and brain injury. I'm going to ask Deborah to be in charge of my slides for me. So if we could move to the first slide.
Okay, there we go.
So here's the standard information in terms of what we're doing. We're going to talk about centrally acting medications in individuals following brain injury, the various mechanisms by which they work, strategies for medication trials, somewhat about the misuse of these agents, and tolerance difficulties and side effects. Next, please. I have consulted and continue to do so for Avenir, which is a pharmaceutical manufacturing company in terms of disclaimers. I've been a paid consultant for other pharmaceutical companies in the past. What we will be talking about today are off-label uses for conditions other than those specifically approved by the FDA in the package insert. Next, please. So, as you hopefully know, the neuron is the basic unit of brain function. There are 10,000 neurons that will fit in the space of an eye of a needle, which is about 1 millimeter. That's an important concept because the average MRI scan, the 1.5 Tesla MRI, gets you down to 1 millimeter. So when you're looking at that scan, you are missing out seeing 10,000 neurons that are smaller than what your resolution is. Mature neurons have specialized functions, although in children we find there is some increased plasticity, and actually in adults there may be more plasticity than we originally anticipated. There are basically 2 types of cells that exist in our brain: neurons, which is basically the basic unit, and then glial cells, which originally we thought acted only as skeletons to support. We now know that they also play a role in, if you will, the climate of the brain and in some of its other types of inflammatory properties. Release of neurotransmitters is triggered by an electrochemical mechanism wherein sodium, potassium, and calcium ions go in and out of the neuron and ultimately allow for the release. Next slide, please. Here you see an image of the end of the neuron. Here is the synapse. So the cell body here is where things are, being produced, and then it's transported in these synaptic vesicles on down. It finally gets down to the end where because of the electrochemical trigger, it's then released into the cleft, being taken up by the next nerve cell downstream. So this is the main area of interest in terms of neurotransmitters. There are multiple different ways by which you can end up with terminating the activity of the neurotransmitter. One is by actually connecting at the postsynaptic membrane. 2 is just by diffusion out. 3 is by coming back on to the presynaptic nerve cell and shutting down production. And then the 4th and 5th are actually 2 different enzymatic mechanisms that basically break down the neurotransmitter. Next slide, please. Neurotransmitters come in many different types. We have the biogenic amines, which we kind of are more familiar with historically: norepinephrine, dopamine, also called catecholamines, serotonin. Notice that the catecholamines generally are excitatory. They increase activity. Serotonin generally is inhibitory. It puts the brakes on. We also have amino acids, which act a little more rapidly than the biogenic amines. GABA is is the most ubiquitous, most prevalent neurotransmitter in our brains. Spinal cord, probably 70 to 80% of the neurons are inhibitory. If we think about watching infants and how reactive they are to stimulation, what allows that maturity of our central nervous system is an increase in GABA neurons, which then inhibits the outflow from those basic primitive reflexes. Then we also have neuropeptides, many of which are more active in terms of spinal level, that react then and work more toward modulating input from sensory nerves, pain, things of that nature. Next slide, please. Nerve cells are powered by virtue of the brain basically uses 2 things, uses glucose and oxygen. There is some suggestion that there are other mechanisms that might be available as well, but classically it's glucose and oxygen. They're taken into these areas here called mitochondria, which is the little power plant, and then the energy of the cell is used both in terms of transporting the neurotransmitters down to the presynaptic area. Energy is also used to create the structural proteins that maintain the cross-sectional integrity of the brain cell, of the axon. Next slide, please. This is going to be one that I want everybody to memorize. Not really. This is kind of the inside view of what happens when brain cells are traumatized and there is a mismatch between the energy need of the brain cell and the energy availability. This has been termed cell suicide. It is one of the mechanisms by which, following traumatic brain injury, we find a change or alteration in axons, or a disconnection, whether you call it traumatic axonal injury or diffuse axonal injury. This is the cell suicide part can take place 4 weeks, maybe even out to 6 weeks post-injury, and is one of the more subtle changes by which we have that disconnection and delayed processing speed. Next slide, please. So neurotransmitter changes after TBI. Deborah, I'll just let you kind of go to all of them. Thank you. So we know that increased neurotransmitter activity specifically correlates with a better outcome. Studies have shown that critters or humans that are more agitated post-injury generally have a better outcome long-term, as opposed to those that are more docile and more lethargic. Studies back in the 1980s actually looked at individuals with frontal lobe contusions And in these individuals, there was seen to be a reduction in serotonin activity. So we think about frontal lobes as being inhibitory and putting the brakes on and modulating behavioral outflow. Much of that appears to relate to a loss of serotonin inhibition in those individuals. Unfortunately, in severe traumatic brain injury and even in moderate and to some degree mild, you will see a decline in catecholamine production over time. This is generally accompanied by a gradual decline in activity levels, increased lethargy, reduction in motivation and initiation. Next slide, please. So neuropharmacologic treatment in brain injury generally is predicated on studies in other populations. There are some studies now that are related to specific individuals with brain injury, but there are very few well-designed randomized clinical trials for brain injury, largely because it's a very mixed population, very heterogeneous. So in many respects, medications we use and that we're going to be talking about are used off-label. Off-label means that the original request of the pharmaceutical company to the Food and Drug Administration for approval of a medication to be marketed is something other than it's being used for in terms of the real world. I'll give you an example. Propranolol, when it first came out, was used as a blood pressure medicine. It ultimately was established to not only help with blood pressure, but also helps with migraine headaches, also helps with intention tremor, also helps with situation or test anxiety. So there are many different off-label uses. Now, for propranolol, some of those the pharmaceutical company decided to go back and do additional studies to get those approved on-label uses, but many times it's just not cost-effective, especially if something is as a generic. So just because it's off-label does not mean that it is improper medicine. Unfortunately, many times insurance companies will say that if you're using something off-label, it is therefore experimental and they will not cover the cost. Typically, that only happens if you're talking about a brand name medication where an economic disincentive exists. If it's an issue of it being generic, most times off-label doesn't enter into their concerns. It's important to understand whether we're treating a premorbid condition. Certainly people can have depression, people can have epilepsy, people can have schizophrenia prior to sustaining a traumatic brain injury. And just because somebody has a traumatic brain injury does not mean that they don't have their premorbid condition as well. So many times we're dealing with that. Third-party reimbursement, I mentioned briefly in terms of the off-label use. And similarly, patient assistance programs are limited. Pharmaceutical companies will have scholarship programs, as it were, that can only be used for the FDA-approved indication. So if there is an off-label use for which the medication is being used, then the patient is not entitled to receiving the patient assistance program. A good example of that is using, in terms of armodafinil, or what's called Nuvigil, as an anti-fatigue medication. It's basically approved by the FDA for fatigue due to sleep apnea, fatigue due to shift work, sleep disorder, or fatigue due to narcolepsy. It also works in fatigue related to depression, fatigue related to chemotherapy, and for some patients, post-traumatic brain injury. Those last three are not approved indications, and so patient assistance programs cannot provide individuals medications for those issues. Next slide, please. It is critical to know, to recognize that you've got to have your basic needs stable before you can see the maximally effective treatment with medications. So it is critical that somebody is getting stable restorative sleep, that they are, and adequate sleep. They are doing well from a pain management standpoint. Nutritionally, they are stable. That is, that they're receiving an adequate caloric intake, that they're adequately vitamin D replaced and B12 and folic acid replaced, that they are stable in terms of the frequency of their meals, etc., multiple small meals a day. Since the brain is 70 to 80% water, in a non-injured brain, a 1% level of dehydration will cause problems with attention, concentration, memory, and your speed of thinking. So in a brain that has experienced an injury, then hydration becomes even more critical in terms of those parameters. So individuals need to be well hydrated, as evidenced by having, urinary needs every 3 to 4 hours with a low concentrated urine. So basically, to achieve that, you're talking drinking 6 to 8 bottles of water a day. Caffeine acts as a diuretic. It makes you urinate more. So if you're drinking caffeine-containing beverages, you need to add extra water. Similarly, alcohol acts the same way, so you need to consume extra water if you are consuming alcoholic beverages. Lastly, we know that studies show that exercise improves the efficiency of the brain 5 to 7 times, and there are many interesting studies now, primarily out of Buffalo and Barry Willer's group, looking at the effects of exercise on recovery following traumatic brain injury. So these 5 parameters really are critical basics to have under as good control as possible prior to really looking at medications. Medications will not be as effective or efficient if these things are not stable. Next slide, please. This is a list of the classes of agents that we're going to be covering over the next 40 minutes in terms of brain injury. The agents generally, we will be using generic names as opposed to brand names as we go through these. Next slide. Anticonvulsants. Anticonvulsants basically are medications that are designed to stabilize the irritability of the neuron following injury. If you think about our neural network as being a system of wires and connections, seizures occur due to abnormalities in the insulation of the axons. So if you've got a crack in the wire or a thinning insulation on the wire, what's going to happen is it's not going to be as efficient in transmitting a signal downstream. These hot spots, depending on where they exist in the brain, will then create irritability that we recognize as post-traumatic seizures. Post-traumatic seizures can range from convulsions, which is something that everybody recognizes as a seizure, to what are termed partial seizures or partial complex seizures, where individuals experience a sensory abnormality, a funny smell, a funny taste, deja vu experiences, a sense of vertigo, a sense of whirling, or episodic losses of awareness of what's going on in their environment. So one of the primary issues for using anticonvulsants, or primary indications, are for post-traumatic seizures. We know that treating individuals for seizures acutely is not something that, for example, if somebody has 1 or 2 seizures in the first week or 2 post-injury, that does not necessarily mean that they've got to stay on anticonvulsant medications long-term. We also know, unfortunately, that just because somebody is on an anticonvulsant early on, it does not prevent, especially in the case of penetrating injury, ultimately having seizures as late as 17 years. Seizure risk for even mild traumatic brain injury is increased anywhere from 2 to 4 to even 7 times, depending on the study, of base rates. So the medications that you see outlined here are various anticonvulsants that work to decrease the irritability of the brain cell, so that either decrease the irritability or prevent the dissemination or the distribution of that irritability or the domino effect of that irritability. Epilepsy spectrum disorder is a concept of partial seizures that occur following traumatic brain injury or other types of neurologic events, in which the individual may experience mood changes, cognitive changes, sensory changes, or motor changes as a consequence of the injury. It is specifically assessed not by EEG, as many of these things are subclinical in terms of the abnormalities that would be seen, but nonetheless, anticonvulsants can be beneficial. Post-traumatic headaches, certainly certain types of headache, migrainous headaches, trigeminal neuralgia, neuralgic types of issues can be helped by anticonvulsants. Explosive disorders, episodic irritability, typically those medications that are most beneficial relate to carbamazepine, relate to valproic acid, somewhat to lamotrigine as well, in helping with those types of behaviors. Similarly, with manic episodes or secondary mania, those may also, again, carbamazepine, lamotrigine, valproic acid can be helpful. Whenever an individual has experienced a traumatic brain injury and has psychotic symptoms, funny smells, funny tastes, seeing visions, even hearing noises, one must consider the fact that that is some sort of a seizure equivalent, and these can be helpful as well. Chronic pain syndromes, by virtue of using medications, either pregabalin or gabapentin most commonly, can be helpful in terms of neuropathic pain syndromes. Next slide. As I mentioned earlier, GABA neurons are the most prevalent in the brain. What happens whenever there is damage to regions of the brain that control that top-down, if you will, inhibition, then it results in increased muscle tone, spasticity that occurs. So classically, in somebody who's had a stroke, what you have is an upper extremity flexion with a lower extremity extension. This increased tone then inhibits, to some degree, normal activity, although sometimes the lower extremity tone will accept to assist in balance. But generally, you try to find ways of minimizing that. You can also have acute muscle strain. Those of us who have been, cleaning our garages and lift things the wrong way can pull a muscle, and then the result is we get a local spasm of those muscles to protect the skeletal system beneath it and to prevent further injury. And all of us, I'm sure, have experienced muscle tension headaches. So the medications here listed are designed to influence, in general, by increasing GABA activity in some way, shape, or form, increasing the top-down control and reducing tone. Botulinum toxin, Botox from a generic or from a brand name standpoint, can also be used for a local type of relief of muscle spasm. whereas these are the upper medications are things that are systemic. Most of the times their side effects includes sedation or some sort of alteration in your awareness or alteration in your level of speed of processing. Botulinum toxin does not, by virtue of the fact that it's a localized injection. Unfortunately, it only lasts about 3 months when it's being used, so it has to be used on a periodic basis. Generally, antispasticity agents are used short-term. They can also be used at bedtime to assist with headache due to muscle tension or muscle spasm. For example, morning headache may represent cervical spasm, and so by using a medication such as tizanidine or Lioresal or not so much dantrolene, cyclobenzaprine at bedtime, you may improve kind of the muscle relaxation at night and have less morning headache. Next slide, please. Antidepressants are arguably among the most commonly prescribed medications in the country right now. Some studies suggest that 40% of the population is taking an antidepressant. Depression is a fairly common disorder with or without traumatic brain injury. 20% of the population will experience a depression in the course of their lifetime. Many different types of antidepressants exist. Generally, their mechanism is by influencing activity of increasing serotonin or increasing norepinephrine, occasionally increasing dopamine. The original antidepressants were actually these down here, the MAO inhibitors. We still use a form of MAO inhibitor in terms of increasing dopamine activity. We'll talk about that in a little bit. Occasionally, these are still used for anxiety or for panic episodes. Tricyclics were the next group that was developed. These basically came out of a search for developing a better antihistamine, which is why this class of compounds has a drying of the mouth effect. They also have an effect relative to making people somewhat sedated. In fact, now doxepin is a more commonly used as an antihistamine, anti-itching medication by dermatologists than it is by psychiatrists. Specific serotonin reuptake inhibitors specifically prevent the reuptake of serotonin at that synapse that we talked about earlier, and basically allows more of it to be available. These medications were introduced originally in the early 80s and developed over the past several decades. Trazodone is a medication that, while it was originally developed as an antidepressant, is actually used more now for problems with what's called DIMS, disorder of initiating and maintaining sleep. SNRIs, specific serotonin and norepinephrine reuptake inhibitors, work for pain states as well as anxiety states as well as mood states. Nutraceuticals are medications that are licensed as medical foods. Generally, they increase or provide extra folic acid. If we consider like pregnancy vitamins or prenatal vitamins with extra folate to prevent neural tube defects, tetrahydrofolate has also been shown as being beneficial in use with antidepressants to improve their efficacy. And they're also a percentage of the population that doesn't have the enzyme system necessary to convert dietary folic acid into tetrahydrofolate, which is the biologically active type in our brain. The main target symptoms for antidepressants are neurovegetative symptoms in depression, as by the mnemonic in sad cages. So reduced interest in activities, sleep, either excessive sleep or inefficient sleep due to early morning awakening, so it's a sleep maintenance issue. Affective disturbance in terms of a loss of the normal variability that we would have. D is for dysphoria. The dysphoria generally is one that has a diurnal variation, and by that meaning most of us as good neurotics, we come to work and we're ready to go, and by the end of the day we're tired and fatigued. The diurnal variation in a classic biologic depression is just the reverse. You wake up in the morning and you feel bad, and you actually feel better as the day goes on, which is a reflection of probably endocrinologic cortisol types of issues. C is concentration difficulty. A is problems with appetite. G is guilty preoccupation, which is a critical issue in terms of determining depression from grieving, is the sense of guilt. E is energy, either an increase in energy and agitation or a reduction in energy, a psychomotor retardation, and then S is suicidal ideation. Antidepressants, specifically SSRIs, can also be used for post-traumatic stress disorder, largely by increasing serotonin activity in the brain. There are other agents, specifically a former antihypertensive, prazosin, which is also used to reduce catecholamine activity, especially at night, that allows individuals to get a more consistent night's sleep without traumatic dreams or the autonomic nervous system hyperarousal. Nighttime bladder difficulties, wetting the bed, can be managed in some individuals by using a low dose of imipramine at bedtime, and that in just a 10 milligram dose can be very helpful in terms of that. Explosive episodes where there is a reduction in serotonin, at times using medications specifically increasing serotonin can facilitate that. Similarly, serotonin mechanisms with chronic pain as well as with migraine can be facilitated in terms of long-term use, chronic kind of management with an antidepressant that increases serotonin. With migraine, you have to be careful that some of the other agents that are used, such as triptans, which increase serotonin, you can develop a serotonergic syndrome, which results in autonomic difficulties, results in gastrointestinal difficulties, and untreated can even result in death in certain individuals. Pseudobulbar affect is a neurologic disorder of pathologic emotion, pathological laughing and crying, either that is out of context to the activity or is excessive to the activity. Many years, the mainstay of treatment was using agents that increase serotonin. There is now an FDA-approved medication that actually uses the effect of dextromethorphan on sigma receptors, in NMDA receptors in the brain to modulate that type of pathologic laughing and crying. This is not garden variety depression. This is not a psychiatric disorder. This is a secondary neurologic event, as you either have to have had a brain injury or dementia or Lou Gehrig's disease or something of that nature before you actually see the pseudo-bulbar affect. Next slide, please. Anti-anxiety agents generally work, at least the ones of the benzodiazepine class, generally work by increasing GABA levels in the brain. The prototypic anti-anxiety agent is ethanol. Ethanol basically exerts its effect in terms of calming people by increasing GABA in the brain. Benzodiazepines that are listed here, whether they are short-acting or long-acting, all work by increasing GABA in the brain. If anybody has had their wisdom teeth taken out, midazolam, which is one of the benzodiazepines that are used for that, you're not really asleep when you're having your wisdom teeth taken out. You are merely under the influence of midazolam, which separates your RAM from your hard drive. So you are amnestic for the procedure. One of the issues with benzodiazepines, especially in our population of individuals with brain injuries, is that it can worsen memory problems in those individuals. So the use of benzodiazepines, whether for difficulty falling asleep, anxiety, muscle tone, it needs to be used advisedly, because you may, if you're using them on a chronic basis, create problems with memory and short-term retrieval. In a situation where somebody is having an acute seizure, status epilepticus, we do use IV benzodiazepines, either lorazepam or diazepam, to control that acute seizure. And in fact, for certain other types of partial seizures, clorazepate or clonazepam may be used to assist in terms of long-term management. Acute aggressive behavior, when you've got somebody who is violent and aggressive, many times using a benzodiazepine to sedate them short-term while you are trying to control and help the kind of adjust the environment is something that is a management strategy. It should not be a chronic strategy for that management. Certainly if somebody has chronic agitation, there are studies that show that the use of buspirone, which basically works on a different form of serotonin receptor in the brain, can be helpful in that. If somebody is withdrawing from alcohol, going through what are called the DTs, using a medication like a benzodiazepine, which also influences GABA activity, can be used for that detoxification as well. Buspirone does not. It is not active with in terms of GABA. It's also one of the reasons why buspirone is not abusable, and benzodiazepines actually do have a fairly high abuse potential. Next slide. Psychostimulants are things that increase generally catecholamine activity in the brain, either norepinephrine or dopamine or both. The various stimulants listed here relate to the ability to increase the release of dopamine and norepinephrine at the synapse. And so these 5 here at the top act immediately in terms of their activity. So you can tell within the first several hours of administration whether methylphenidate, aka Ritalin, or lisdexamfetamine, which is aka Vyvanse, if those things are working. In contrast, things such as atomoxetine, also known as Strattera, or guanfacine in Tuniv, take a longer period of time to work because they're working at a different site in terms of the synaptic reuptake or the activity postsynaptically. So within a 2 or 3 day period, you will know if these medications are working to help with attention and concentration, or to help with fatigue, or to help with narcolepsy, or help with initiation. whereas a clinical trial of these generally are going to take anywhere from 3 to 6 weeks to know that it's making a difference. For that reason, these stimulants up here are also more abusable and are more tightly controlled by the DEA in terms of dosing and prescriptions. You cannot write for refills. You can get a 30-day supply. These are also the kinds of things that if the dog eats your prescription or you misplace it or whatever happens, it gets stolen, physicians are not permitted to replace those, as these have a street value and are abusable. Psychostimulants generally are used with caution in individuals following brain injury, largely because of that potential for abuse or diversion. However, they can be extremely beneficial in terms of helping people get back to a more normal life. As a clinician, if I'm using a stimulant, especially in a college student post-injury, there are many things that are required in terms of keeping their medication locked in a secure place in their dorm room or apartment. They are also told to, or instructed to not tell people they are taking these medications, as they will be frequently harassed to either give them or sell them to their colleagues or co-students, or actually, have them stolen. So while these are very effective medications, they also require a little more sophistication, a little more structure in terms of their use. Next slide, please. Damage to the frontal lobes, specifically the right frontal lobe or orbital frontal regions, can result in impulse control issues. Many times this relates to an impairment in time sense. It relates to difficulty with serotonergic mechanisms in terms of putting the brakes on. Listed here are medications typically that are used for those individuals. Lithium is one that historically, since 1947, has been used for mania. There is concern about using lithium in some populations post-traumatic brain injury, largely because it, in toxic levels, it can cause dulling, and especially in Virginia or areas where we have hot summers, if we start sweating, we will preferentially retain lithium and lose sodium, and levels can become toxic if we're outside engaging in activities. Former anti-hypertensive agents are also used, this in terms of postsynaptic alpha activity, this in terms of beta blockade, to decrease agitation, decrease impulsivity, decrease aggressive behavior to some degree. Similarly, these 3 anticonvulsants, as we mentioned earlier, can be used as well. Again, if the mood disorder is periodic and you've got highs and lows, these are the kinds of medications you would see being used. If somebody has a depression and an antidepressant alone is not working, protocols that add these medications to that antidepressant can help in terms of that treatment refractory depression. Aggressive behavior, as mentioned, mainly with clonidine and propranolol, also valproic acid can be used. And certainly if somebody is having seizures and in between they have more disruptive behavior, these would tend to be the 3 medications that one would tend to gravitate toward to assist with that. Next slide, please. Cognitive enhancers are medications originally developed to assist in the management of Alzheimer's dementia. These agents generally increase acetylcholine levels in the brain, such that it improves retrieval of information. There are a limited number of studies now, specifically with donepezil, rivastigmine, and memantine in terms of specifically traumatic brain injury. So they are less off-label, if you will, than they used to be. The use of cognitive enhancers in terms of traumatic brain injury is one that is somewhat variable in terms of how people apply it. Studies have shown that many individuals by the age of 50 or 55 following a significant traumatic brain injury will begin experiencing cognitive changes such that they have more difficulty with retrieval, with registration, and the ease with which they can function independently in the community. By using these medications in a preventative way, these medications do not stop the underlying pathologic process. What they do is slows the decline, and they slow the decline. If you stop these medications, the decline will happen much more rapidly in studies. So this is more of a prevention type of issue. Ginkgo biloba is a supplement that has been touted to have cognitive enhancing. The studies are fairly mixed on the efficacy. One of the difficulties with this particular compound is that it also does tend to cause some thinning of blood, if you will, so it makes it the coagulation a little less and can create difficulties in folks that are on other type of anticoagulant therapy. Studies have shown that drops in estrogen levels result in problems with working memory and with cognitive efficiency. And so the use of estrogen can also be restorative of that. Now again, because of concerns of breast cancer and other uterine cancers, the use of estrogen for postmenopausal cognitive issues is generally not done, but that may be one thing to entertain as well. Omega-3 fatty acids, medium-chain triglycerides are two mechanisms by which providing building blocks for either reducing oxidative stress or promoting a more stable glycemic index can help with cognition stabilization. And then folic acid and vitamin B12 supplementation can also make a difference as well. In elders that have sustained a traumatic brain injury, the use of these medications on a much more rapid timetable is not uncommon. If an individual happens to possess the genetic marker ApoE4, that is also something that might trigger the earlier use of these medications in individuals to, again, slow down the decline in cognitive function associated with the triggering by the traumatic brain injury of an earlier dementia process. Next slide, please. Antipsychotics generally work by blocking dopamine activity in the brain or by enhancing certain subtypes of serotonin receptors. Generally, antipsychotics are not used following traumatic brain injury because they slow recovery in terms of learning and rehabilitation. However, many times they become necessary in terms of significant psychosis, especially in somebody who has a pre-existing psychosis or somebody who has significant agitation or aggression. They also are used, dopamine blocking agents are used to prevent vomiting. So anybody who's taken Compazine has had a dopamine blocking agent. They're also used to potentiate narcotic analgesics, and they're also used if somebody has GI hypermotility. Next slide. Antiparkinson's agents are agents that generally increase dopamine activity in the brain, either by being a synthetic dopamine or by providing precursors to produce more dopamine or to reduce the breakdown of dopamine in the brain. Conversely, there's a balance between dopamine production and cholinergic production, and so by dropping the cholinergic levels, by using anything from this category can provide some balance as well, either in isolation or in tandem with dopamine agonists. So these are generally used for Parkinson's syndrome, the individuals that have the shuffling gait, the mask-like faces, the cogwheeling, the micrographia as they write things are smaller. Can also be used for individuals who have decreased initiation or motivation. So specifically, amantadine is a medication commonly used for frontal lobe individuals with frontal lobe dysfunction where they have a hard time getting their starter switch going. Swallowing difficulties are many times dopaminergic mediated, and so the use of a dopamine agonist can be helpful. To some degree, they help with attention and concentration and fatigue. To some degree, again, with cognitive endurance, amantadine may make a difference with that as well. Anticholinergics, in addition, have been used for some coma stimulation issues to help with excessive drooling post-injury, vestibular dysfunction. If anybody has taken a seasick pill or used a patch, that is an anticholinergic that helps with balance issues and dizziness. And in some children with brain injuries, the linkage between vestibular overstimulation and being tactily defensive can be managed by use of anticholinergics as well. Next slide. In general, the therapeutic concepts are that you want to make sure that you're getting the medication into the central nervous system. You start at a low dose and you go slow in terms of advancing it because individuals with traumatic brain injuries and brain injuries generally have a lower threshold for developing side effects. Duration of the study or the trial is appropriate to the half-life, so something like a stimulant, a few days will show it to you, whereas something like an antidepressant or an anti-seizure medicine is going to take several weeks or a month to show it. You want to monitor the target symptoms, change only one variable at a time, and if the individual shows a positive effect, the only way to know whether it's working or not, or whether it's a spontaneous remission, is to take the medication away. If they stay better after you take the medication, it ain't your medication. It's just nature. Next slide. Thank you very much. Unfortunately, I don't think we're going to have much time for questions, but I will be more than happy, as Deborah said at the outset, to respond to your questions and appreciate your all tuning in today. Thank you.
Okay, thank you very much. Thank you, Dr. Oshanik. And if you do have questions, like he said, feel free to give us that information and we can get that question answered for you. And thank you so much for joining us.